Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Dr. Matt Kaminsky is a trauma surgeon at Cook County Hospital in Chicago. He talked to us in this episode about what it is like to be a trauma surgeon at one of the busiest trauma centers in the U.S. He also talks about his unlikely journey from Winnipeg, Manitoba to Chicago and what trainees at all levels can learn from that experience. Make sure to check out our YouTube channel for the Canadian Journal of Surgery, where we have posted Dr. Kaminsky's short yet very effective trauma mini simulations. Links are in the show notes, and enjoy the episode.
Dr. Kaminsky, thank you very much for taking time out of your busy schedule to come and chat with us on Cold Steel. We really do appreciate it. And for those of us who don't know you as well, can you tell us a little bit about where you grew up, your training pathway, and how you ended up in Cook County?
Yeah, so basically I'm a Winnipeg, Manitoba kid. So that's where my initial formative college years were. I did medical school there at the University of Manitoba, followed by general surgery residency there. I came to Chicago after that to do a trauma surgery fellowship here at the Cook County Trauma Unit, and then I subsequently went back to Winnipeg for a critical care 2-year critical care fellowship. And although I went back for the critical care, I kind of never left Cook County after trauma. And I took a job here after and have been enjoying it ever since here in Chicago.
There's a few iconic public hospitals in the U.S. I would argue, being biased a bit, Grady in Atlanta would be one, Bellevue in New York City would be one, maybe even LA County in LA. But certainly Cook sits as a member, if not above that crowd. So tell us for people who maybe haven't been there, haven't had the pleasure of visiting, or certainly training there. What's it like to work at Cook? Like, how would you describe it? Maybe even put it in the context of Canadian hospitals where most of the listeners would have been working.
Yeah, well, it's neat working at a legacy institution or a legacy trauma unit. And, I guess it depends on the person, but I really, really enjoy looking at the old building on Harrison Street here, like the old Cook County Hospital, and looking at the old roster, just the hundreds and hundreds of people that have rotated and learned through here. And I find that you have this weight, and you're on the shoulders of giants. Everyone's heard that term before, but you really are. And with that comes experience from an institutional perspective in your group. So when we do things a certain way, there's usually a pretty good reason for it to be like that, and it's out of experience as opposed to just someone deciding to do something a certain way like that. And obviously, North America has many legacy institutions, and even locally, for example, the Winnipeg General Hospital has a lot of really cool history if you look back in the rosters of any major Canadian hospital. But I think that the biggest thing is that you have over 100 years of a huge roster of people coming through and training here. I think at one point in North America, roughly a third of surgical trainees had either trained directly at Cook County or rotated through. So at one point, virtually everybody had trained in some way, shape, or form at the Cook County Hospital. So again, you might not feel it on a day-to-day basis per se, but it is neat how you have this weight behind you when you do things. Kind of hilarious as well. Some legacy trauma units get into a certain frame of mind, and it's hard to move them, so they may not be as adaptable as newer or other trauma units. So there's maybe some negative sides to it, or depending on where. But I'd say at Cook County, we've always been try to maintain the leading edge of trauma care. We've always felt that that's the most appropriate way to do things, and that's been how we've done it since day one. Cook County being one of the first organized trauma units in North America, we try to continue that legacy to this day.
It's interesting when you walk into Cook or you walk into Grady, as two examples. You and really honestly, independent of your level, whether you're there as a visitor or a trainee or a guy like you who's now working there, you feel the exactly what you're saying. I mean, you feel that weight, and even more importantly, I think you feel this almost overwhelming commitment to patient care that seems to be, unifocular. It's palpable. Do you feel that on a daily basis at Cook, and how do you process that kind of privilege and that kind of commitment in and amongst your colleagues and your institution?
Yeah, for sure. And I think it depends on the individual. There's some people that just walk in and it's just like any other hospital. But if you open your eyes and you look around and you look at the legacy wall and the history, immediately I personally get that feeling that is very palpable. With that, I feel almost comes a responsibility to maintain the mission. Again, the mission here has always been to provide care to the people that can't afford it, and we save the people that nobody else wants to save. That's been the mission since day one, actually very Canadian, and I feel very, very much at home. And so on a daily basis, working here is very much in tune with my frame of reference for the world, and so it's very easy to come to work and to continue on this mission. It's not a problem. It's not a job to me. It's like all of this is fun. So going to work is like going to play on a daily basis.
Amazing.
Can you, for those of us like myself who haven't ever been to Cook County, can you tell us a little bit about like what is the setup like for trauma? Is it similar to how things are set up, let's say in Winnipeg or in other Canadian hospitals in terms of the trauma service, the emerge, or is Cook County very different than other places you've worked?
So Cook County, unlike most other trauma units in North America, is essentially a standalone department. And so it's not a section of general surgery or of surgery. It's its own department, as well as its own ER for that matter. So we manage people from start to finish as a completely independent unit within our hospital. So with that comes it's actually a lot easier to see patients right from the start of their care all the way to their rehabilitation plan and discharge planning. So we're not consulted down to the ED to see someone already 5 to 10 or 30 or hours into their care. So we see them right from the start. There is, in order to be admitted or sent to the trauma area, you have to meet a injury criteria. So it's not like we see slips and falls and minor orthopedic or minor cuts and bruises. you have to meet a level of injury to be sent to the what we call the trauma front room or the trauma ER area. There, the attending on call, myself and my peers, we work with surgery residents as well as ED residents under our supervision, and we manage all aspects of care, including all of the airway, central access, et cetera, et cetera. So we don't need to shove other practitioners out of the way. We are in the driver's seat right from the start. So it's quite easy to manage a bunch of people like that. We don't have to be unnecessarily consulted, or occasionally, as happens in other EDs, you're consulted possibly a little bit late in the patient's care, and you feel like you're behind the eight ball for the rest of the day or for the rest of the time you're working on this patient. You might think, if only I had known an hour ago or seen the guy right from the start, we could have avoided a particular outcome.
It's interesting, Matt. That structure, you kind of described it very eloquently and nonchalantly, but it's such a challenge in Canadian trauma care. Not that collaboration with emergency room physicians and the emerge in general. A general emerge is not great, but there's certainly examples of delays to care that really challenge our ability to achieve some good outcomes in those sickest of the sick patients. So,
yeah, and I don't think people do it intentionally, or people have egos. Every doctor wakes up in the morning and goes to work wanting to do a good job. Nobody wants to not do a good job or not do a good service to patients. However, in the moment, you'd be surprised how very smart people and a trauma team can fumble the football in a high-stress moment. I find it fascinating, like, why is that? Why is it when a particularly stressful event or patient comes in that needs to be managed promptly, it seems like practitioners' decision-making or team skills can fumble, and I'm always curious why that is. I find it quite reversed here, where as soon as we have a very sick patient, it's unfortunately quite common here, but the team locks in, and the resuscitation and the whole process can be quite calm and collected. And there's no egos or fighting decision-making elbows or punches, depending on what happens. But it is nice to have a straight order of command here. And things can be actually quite calm. And I think, overall we do a good job of it here. And I think that at other places, depending of the relationship between the ED and the trauma service, maintaining a level of collaboration, just so you know that, who's in your back pocket, so that you can have a good outcome for the patient, particularly in the stressful environment or the stressful high acuity type of patients.
Yeah, no, it's so true. And the reality is, the challenges that you described become larger, of course, when your volume probably gets less. And if you see a really severely injured patient, based on your shift work pattern or your practice, once a month or once every couple of months, it's hard not to reinvent the wheel, and it's hard to achieve that flow and that calmness, and in particular that quietness in the trauma base. I think that's something that we certainly struggle with in Calgary and in lower volume centers than say yours, no doubt.
Yeah, and I guess the subsequent question is, how do you optimize the team for that? So an area of research that I kind of do is very, very simple tasks. We have a laminated card with a picture of stab wounds to the cardiac box, and I just grab my residents and nursing colleagues, actually, and just the whole team, and I say, pretend arrest is coming in, and we go to the trauma area, and I just put the card on the table and describe a situation. And we basically go through an intubation. The intubation doesn't go well, so we have to crike the patient. Then the patient arrests, and we have to do a thoracotomy. And the whole thing takes about 5 to 10 minutes, and it's basically like a critical systems walkthrough, and as well as a systems check. So if we have to crike somebody, the resident physically looks at where we have the knife and the crike kit, so that we know where it is. So you'd be amazed how just seeing and touching and just confirming we have all of these critical systems within a few hours or a few days, we end up using all of these items, and it's great when the team on call has confirmed these items, and they've confirmed the team, especially when we have the nurses with us. And the whole process takes 5 to 10 minutes. So I think every institution's different, but a few simulated case scenarios, particularly in the actual environment that you're gonna be working in, to do a few little dry runs. And it doesn't have to be a long sim where everybody sort of rolls their eyes and everyone has work to do, but you could do these things fairly efficiently, and as a critical systems check, a team check, and it only takes 5 to 10 minutes. And it's a very small investment of time that pays dividends should you actually need to use these items.
We can't not have you on the podcast and not ask, what's your greatest or craziest story from working at Cook County?
The greatest story that you can tell publicly on a podcast is what he meant.
Yeah. I have to admit, I've seen it all. If you were to scroll through my pictures on my cell phone, you'll see again crazy gunshot wounds and things that you thought would be impossible, ligated IVCs, aortas, thoracotomies, various implements through body parts, everything. And then as you're swiping through, then there's pictures of my kids or my car or trips. So it's kind of hilarious if you were to just scroll through my pictures. I think you'd have just an absolute, that's my life, but it's a whole crazy mix of all kinds of insane events.
It's funny you say that, Matt, because you and I were talking about this, but since I was down in Chicago with you, John Corpeak, for those who don't know him, as a Canadian leader of trauma, he was just recently on a plane, and they pulled off, when he landed back in Calgary, they pulled off all the essentially middle-aged Caucasian males, and they pulled them through security, and they looked at all of their laptops and their phones, and we can only guess what they were looking for, but he said, after about 10 minutes into looking through all of his pictures, because they were exactly the same as yours and mine and all of us, it was crazy injuries and kids, all the security guys were all huddled around the computer with their minds blown. So I thought it was fantastic.
Hilarious. Yeah, and I think, my literally last case I did yesterday, gunshot times 21, so 21 holes. So he came in peri-arrest, thoracotomy, his heart's beating, OR, and it's amazing. And Chad, you're at this skill level, but you have a Cattell brash, Maddox, everything exposed. I'm not kidding you, within 60 seconds. And it's done, I'm not a cancer surgeon, so I do all of this with blunt or with a curved Mayo scissor, but it's unreal how once you're in this business, how fast you can get, and when your skills are just honed in. And this guy had a left renal sort of blowout right at the aorta. So we got some clamps on it, controlled the bleeding, and he came to the ICU, damage control. Unfortunately, just physiologic exhaustion. He ultimately expired, but he was alive for 12 more hours. And had he not been transferred from another outlying facility, so had I got him, honestly, I think if I got him 10 minutes earlier, I would have saved him. But perhaps it's just neat where you could see people go to that physiologic point of no return on a regular basis, and you're trying to pull them back and save the 1% that would not make it anywhere else. Like, we're trying to save the people that are right at that brink, and I feel quite fortunate that I can have a part in this person's worst day ever. But you're trying to work on it. But I've seen it all. I can't think of particular cases. I've had gunshots to the heart, asymptomatic, bullet emboli. Again, gunshots to the head, and the guy's GCS-15 wasn't even aware that he was shot. And then just the hilariousness that can happen on a busy night in a busy American trauma unit. You name it, I've probably seen it a couple times.
Matt, one of the things that we've noticed as kind of a bit of a pattern, and certainly not to say it's everyone that we've interviewed and talked to, but there's no question there's a significant group of folks that we've talked to that really have special partnerships with their subspecialty group. And, from the outside, having met you guys, I would certainly classify your group, your trauma group at Cook as that description. We've heard from you about the structure and the volume and the content, but tell us a little bit about, your partners and what makes your group so unique and so special.
I think what's very empowering here is that because we see so much surgical pathology, the philosophy here, again, and this has been since day one, is that we can manage everything surgically, and absolutely everything. And we have the ability and support from our subspecialists is that we can go into any compartment in terms of damage control or anything. So I do cardiac surgery, I do vascular surgery, I could go in the neck and chest. I won't do brain surgery, but if I had to, I could do that, and I do minor orthopedic stuff. So from our subspecialists, the understanding is we're allowed to do that. And they support us for that because they're elective surgeons. And so there's a difference between being an elective cardiac surgeon and being a trauma surgeon. The disease process is different. So by any means, we are not consultologists. So we don't give up our surgical procedures to subspecialists unless we specifically ask for it. Obviously, orthopedics, neurosurgery, that has to be done by those procedures, but it's done after we consult them for those specific items. I think 50% of my case logs are in the chest. I've always enjoyed thoracic surgery, so it's really cool that we get to do all of these things. And even in the postoperative course, if we have to do a VATS or video thoracoscopic drainage, I'm very well versed in that, rib plating. So it's fun that I'm not just doing appies, choles, and hernias. I get to do thoracic surgeries, and again, gunshots to the heart or stabs to the heart. I'm very comfortable around these compartments, as well as major vascular liver. My hepatobiliary skill set is probably different than yours, Chad. Every time I'm in that area, it's usually dog meat, but I can usually control the bleeding, but I might not be as eloquent as you.
Oh, I don't know about that, dude. I don't know. Well, the next thing I wanted to talk to you about is, as you're aware, Morad Hamid published two sort of surgical magazines called Roscoe, and you were involved in an article that talked about the spike in the violence epidemic and really gunshots in Chicago. I think it's probably quieted a little bit now. You can correct me if I'm wrong, but what can you, for those who maybe didn't read that really superb article or don't really know a lot about it, what was going on there, and what was Chicago like at that time?
Yeah, and no one knows exactly, or everyone has various theories. 2016 was one of the most violent years in Chicago in a very long time, and so I think generally, for example, Chicago was averaging maybe low 500 murders a year, most of it by gunshots. In that period, we were around the 800 murder level, so a huge spike in murders. And along that, you could imagine just how many people were shot or severely injured. Again, most of this is all gunshot wounds. Exactly what occurred, I don't know if it was a drug war, different fads of drug use or something. It's a bit unclear. But that winter, going into 2016, we knew it was going to be a bloody summer, because usually, even in Chicago in the wintertime, things slow down and we're on a different pace. But the pace was relentless at that time. So we had, at any given time, a full ICU, or our trauma ICUs, 12 beds. It was full all the time. And we had half of them open abdomens in various phases of their trauma laparotomies and closures, and we just kept on getting them. And so it was relentless. The cause is unsure. Again, these are these crazy things that happened in Chicago. It's a railroad city, and a container from the Ruger, I think it was the Ruger gun manufacturing company, one of the containers got broken into, and so into the south side of Chicago, wow, a container full of high-powered military rifles were released. And so in 2016, most of our stuff is low velocity arms, so pistols and occasionally shotguns and stuff. But we were having essentially military wounds during that period. It's quieted down since, but two gang factions were going at each other with high-powered arms, and so you could imagine the injury patterns of that. So I'm not a military surgeon at all. I've never been in military combat, but during that period we were getting military type of injuries, and it's just night and day the difference in wound patterns and the severity that occurs with these type of wounds. So the initial question of why, I have no idea. If someone knew, they could try to fix it. It predates President Trump, so this was on Obama's watch, the violence in Chicago, but it has since subsequently gone down. But we can't blame President Trump on any of those years there.
Well, one of the things, Matt, you and I have talked about is sort of accessing amazing places or people or training programs, in our case, within trauma, from where you start. And by that, I mean, as an Alberta boy coming out of this province, the training that I received in South Africa or Colombia and eventually Atlanta, really, there was no local link to those places. That was something, in my case, I had to figure out. And you have really the same story about Cook coming out of Winnipeg. There wasn't a friendship or a link between those institutions. So I wondered if you could maybe talk about doing that a little bit and provide some advice to maybe students or residents or even fellows that are in those scenarios across Canada. Because I don't think it's uncommon across the board, and certainly not uncommon outside of trauma as well.
Yeah, well, in typical Winnipeg fashion, my path to Cook County started with a frozen battery in a car that wouldn't start, and so I was on I think a cardiac surgery rotation. And as I was going to the parking garage at the end of the day, the cardiac anesthetist was coming back into the hospital, grumbling that his car had frozen over and wouldn't start. So I drove him home, and as we were chit-chatting, I said I was interested in trauma. I was still PGY2 or so, and he had trained at WashU in St. Louis and was co-fellows with a trauma surgeon at Cook County, and so he forwarded me her contact, and I subsequently arranged a resident elective rotation here as a PGY3. I loved it, and then again applied for the fellowship and got it. So again, my direct path to Cook County was a frozen battery. I probably would have looked it up and cold called some places, but having rotated as a resident, it made me know what I was going to get into if I were to choose this fellowship. I knew the staff and everything, and really wanted to be here for my trauma fellowship. So I think that it's just amazing that I know residents often want mentorship, which is very, very important, but also to look for the opportunities within your network of people to because if you think of it, the medical and surgical community, actually the surgical community specifically is pretty small if you think of it, and so everybody kind of knows each other, but look at who you know, and to capitalize on opportunities, and even to backtrack, just to look for those opportunities should they occur, because you'd be surprised how your cardiac anesthetist knows trauma surgeons in the U.S. or your faculty in a small town in Canada somewhere might know some big people or at some big institutions, and it's amazing how just a quick email and a good word can get you a life-changing rotation as a resident.
Yeah, it's so true. And I think we all have to keep in mind, certainly as we're coming up, that most of these quote-unquote big or iconic people or places, they're in it for the right reasons. They love to train, keen, enthusiastic folks from anywhere in the world. And so they usually are quite approachable once you figure out how to link in with them, whether that's, like you said, cold calling them or a connection or emailing them or whatever. People shouldn't be nervous about that. They should pursue that and be motivated by it for sure. But
or just going to expand on that. Occasionally, people I think our residents feel or students feel that their mentors will make their career better, or if I know this guy, it'll make my career better. I think ultimately the resident's still responsible for their career, and if you're passionate about whatever area you're interested in, that just lights up your mentors and your contacts to just make things better for you. So if you see a brilliant individual that loves trauma surgery and is just gushing it out, it motivates your mentors and all the people around you to make things happen your way. If you're a future hepatobiliary guy, and you could see that, it's not hard to motivate a guy like you, Chad, to just like, wow, you're spectacular. We got to get you. You got to go talk to this person, but ultimately it's that resident, and I think whatever specialty or whatever you're passionate about, if you exude that, it's very motivating for the people around you to make good things happen for that.
Yeah, I mean, it's at the trainer level, right? It's such a selfish pleasure to be around those people that are so motivated. It's rejuvenating. It's so fun, for sure. The last question I wanted to ask you, Matt, before we let you go, because I know you're busy today. Surgical education is clearly a 30,000-foot term, and means, maybe it's a bit nebulous and means different things to different folks, but you're clearly a guy from Winnipeg through your fellowship at Cook all the way to the end that really, I think, got the most out of your training environment. You're sort of touching on that or dancing around that right now, but what would your advice to trainees of all levels be about getting the most out of your training and the mindset with which you'll mostly succeed?
Yeah, I think, again, from a 30,000-foot perspective, always to be true to yourself. I know that sounds very cliche, but occasionally you'll see residents focusing on a specialty, and I think that they like the people that are in that specialty, but they may not, or it appears that they may not really be passionate about that area. So to just be cognizant of that. So residents should always be really focused on what they enjoy on a day-to-day basis, whatever that may be. And that could be very bread and butter general surgery or rural surgery. It could be on the critical care side. It could be breast, whatever it is. To ask yourself, do I really enjoy this? And I really want to. I think residents, if they focus on an area that they really find easy or enjoyable, to capitalize on that. You don't have to be anything in particular. Subsequently, I think use your, or I guess the other thing is your 5 years of surgery training or your residency. Consider it a 5-year interview, and so people that are your teachers or within the hospital, to be cognizant that in a couple of years these might be your partners, and so to be to capitalize on your relationships and maintain a good relationship with all of your faculty members, even ones that you, as a resident, you might feel have no immediate means to your fellowship or your goals. You'd be surprised how, like I said, everybody knows each other, and to maintain maintain those contacts. And then probably last thing, I think a positive can-do attitude is really important. The medical world, hospitals, it's basically like, and surgery in general is just a series of frustrations back to back to back to back, and how you manage that. And so a positive resident and a can-do attitude can be quite refreshing. And those are the people that hospitals want to hire, people that are looking to make things better in a positive way. There's no shortage of things to complain about, but people that get hired are the ones that have that skill set or that attitude that will change things for the better.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.